So hello and welcome everybody. My name is Ryder Gwynn and I'm a neurosurgeon who's been practicing here at Swedish for about 16 years now. I'm the executive medical director for Swedish Neuroscience Institute, and I'm fortunate to have two guests today for a amazing conversation that I think we're going to have. We have Dr. Jim Bowen, who is a neurologist and is the medical director of the MS Center here at Swedish. And we have Dr. Nancy Eisenberg, who is also a neurologist specializing in dementia and Alzheimer's, and she is the medical director for the Center of Healthy Aging here at SNI. I want to first just recognize that this is a very unique moment in the world, and I want to thank you for the time that you guys are investing with us today and have given us today. It's a time when the world has been experiencing a really unprecedented amount of isolation due to this pandemic. And this is part of the reason why we really wanted to highlight and celebrate two physicians here who are trying to bring patients and families together for better health and better wellness. We'll be having a conversation about the current and the future state of these two amazing centers here at Swedish. We want to talk about how this model of care differs from the standard clinical care and how community not just provides the best medicine, but is the foundation from which these centers really flourish. So I'd like to invite feedback with questions and answers at the end of the session. And if you'd like to continue the conversation later, let us know, and we'll give you information at the end of the webinar on how to do that. So we thought we'd like to get you to know us a little bit better, and we thought it'd be nice to say a little bit about what made us choose to go into the field of neuroscience. And so I'll start first, and then we'll go to Dr. Bowen and Dr. Eisenberg. So as a neurosurgeon, I chose to go into neurosurgery really because I wanted to find out what makes us tick as human beings from a psychological aspect, human aspect, and cognitive aspect. And I thought that the study of patients who have epilepsy actually gave us amazing clues on how our brain is put together and puts together thought, emotion, memory, personality, kind of everything. And because of this, I went to do a fellowship in epilepsy surgery for a year at Yale after finishing my neurosurgery training right before coming here to Swedish. Over time, though, things have kind of changed a bit. I don't get most of my reward from that intellectual kind of investment, but rather from really the appreciation of the people that I've helped. And kind of, for example, 2 days ago, I got a letter from a patient I operated on 10 years ago who took the time to send me a card and say she just was really happy that she's been seizure-free for 10 years now due to the surgery that I did. And so kind of what got me into neurosurgery and what kind of keeps me and sustains me now has definitely changed over time. So that's me. Dr. Bowen, what has brought you into the field of neurology?
Well, I don't have a personal connection with anybody with neurologic disease or with multiple sclerosis, but I got into this field because I like a challenge. And when I first went to medical school, the most feared class is neurology and neuroscience. So I thought, okay, that's for me. The second most feared class is probably immunology. So what could be better than to put those two things together? So I headed in that direction, and not very many of my classmates did because they are very difficult courses and a lot of difficult material to learn. And then once I started getting out into practice, the biggest neuroimmunology disease is multiple sclerosis. And once it became known that there was actually somebody interested in multiple sclerosis, then people started sending me all their cases because they did not want to deal with it. Next thing I knew, I was running an MS center. So that's how I got into it.
Great. Yeah, thank you very much. Dr. Eisenberg?
So I do have a very personal story. I was really close to both my grandparents who lived quite a long life, and I remember playing gin rummy with them, and I saw my grandmother who developed dementia in her 80s and my grandfather who lovingly cared for her. And I think that was my first exposure to dementia. And then in medical school, I too like a challenge. And so I studied public health as well as medicine. And I'm fascinated by the fact that our thoughts and our feelings really inform our experience. And you know, what we were taught in medical school, which is you're born with a set of neurons and that's it over a lifespan, has absolutely been refuted. And we know, for example, that our experience is also shaping our brain, our mind. And so to think about this experience dependent neuroplasticity and the skills that we can cultivate over time to prolong health span has really been my service and my care that I try to offer to patients and families as they age. Yeah, and so it's in that spirit of health and hope that I practice medicine.
Great. Wow. Those are awesome stories. Thank you. Great. Well, let's kind of move into the next phase. And I think for 30 minutes now, we're going to do kind of a question and answer. I'll pose questions to both of them and they'll answer. And during this time, please put in questions into the question and answer window. And then we'll get to that afterwards for another 10 to 15 minutes. So first, I think I'll start with Dr. Bowen. And first question for you, if you can just tell us, what is a comprehensive center? What makes it comprehensive?
Well, I think different people mean different things by comprehensive centers. And generally, you have a lot of services combined into a comprehensive center. But different models, they may have these just in a single institution spread over multiple campuses or things like that. So our model and what I think of when I think of a comprehensive center is that we are able to address all of the medical aspects of care. And in my multiple sclerosis area, that would include neurology and rehabilitation services, MRI, neuro-ophthalmology, things like that. It's actually too much to fit. We have a very large center, but it's too much to fit within the center. So neuro-ophthalmology ended up 2 floors above us and MRI 1 floor below us, but it's all in the same building so that people have minimal areas that they have to go to, and they don't have to go, they can do it all on one day. And don't have to travel once they get onto the campus. The other thing, though, is that I view comprehensive care as more than just this medical model. And there are other aspects to people's lives that contribute to their well-being. And this would be typically people divided into physical well-being, emotional well-being, and social well-being. So we've created structures to try to help support people in those ways that are well beyond the typical medical model, and have incorporated those into our center and the care that we give. As a result, I think that we are probably the single most comprehensive MS center in the entire country and perhaps the world. But we try to incorporate all that medical, physical, emotional, and social well-being.
Great. Fantastic. Thank you for that. I actually just made me think I have a friend who lives in Bellevue who has MS, and she will not cross the bridge and come to Seattle for any reason other than to come and see you at the center there. So I think that's a testament. Yeah, Dr. Eisenberg, can you tell us about the Center for Healthy Aging? For someone with Alzheimer's disease or dementia, what is different about the care that you provide compared to someone else?
Yeah, so first of all, that is so inspiring what you said, Jim, and how amazing to have such comprehensive care. So the Center for Healthy Aging also aspires to provide comprehensive and collaborative care, which focuses on the person and the family. So comprehensive for us also encompasses family-centered care, really looking at health span, quality of life, and advanced care planning for the prevention, the evaluation, and the treatment of people with Alzheimer's disease and other dementias. And we also offer, well, we're building now. So what we're building is eventually a care model, like you mentioned, where you'd have well-being services and programs focusing on lifelong learning, creative aging, early memory loss prevention programs, these kinds of programs. And this comprehensive care model would also be one visit with a cognitive specialist, a neuropsychologist, a social worker, a speech therapist, and also possibly a shared medical appointment to support sustained behavioral change, because we know that lifestyle modification is so critical, not only for the prevention of dementia, but also for the treatment to slow the course. Mm-hmm. We also know that if the caregiver, the care partner is unwell and is not flourishing, then the individual who's experiencing dementia is not able to thrive. And so we know that really true thriving is mutual. So that's another way to conceive of comprehensive collaborative care.
Okay. Thank you. That's great. You did mention also the prevention. And so that kind of makes me curious. You know, I have had multiple family members with Alzheimer's, and we would have loved to have caught things before. You know, how do you know when to bring somebody in for that prevention?
Yes, so that's a super question. And we know that fewer than 1 in 2 cases of dementia are diagnosed in primary care. So we have ongoing efforts to collaborate with our primary care colleagues in the front lines to improve that detection and then to really focus on prevention. And there are components of prevention that I'm happy to speak about, but really critical to detect it early. We know that these changes in the brain accumulate over decades, and there's an opportunity over time to really bend that curve. We also know that 1 in 3 cases of dementia are preventable. And there was a recent study that identified 5 factors that in a group of 3,000 folks over 6 years, where their dementia risk was reduced by 60%.
Wow. It's amazing we have that much control over it, you know.
That study just came out last week.
Oh, amazing. All right, great. Well, thank you. So Dr. Bowen, you've kind of touched on this a little bit, but if you can elaborate why the supportive services are such an integral part of your care for your patients in the MS Center.
Well, multiple sclerosis takes so much away from patients. It hits the average age that they're diagnosed is between 20 and 50. So they're right in the middle of their peak earning years. They're starting their families, and they have this whole life, and then suddenly MS intervenes. And it's really hard to put that back together. And I think supportive services are important because me as a single neurologist don't have the knowledge or the time to deal with all of these aspects of their care. So we put together a rather large team to support us. And just to give some examples of how this is, like for their wellness within the community or their emotional support, we have a psychologist and psychiatrist to help with the emotional aspects of it. Kind of related to that is that we have a vocational counselor to try to keep people in their jobs. So about 2/3 of what she does is work on workplace accommodation so that they can remain employed. We have a social worker to help connect them with social services. On a rehabilitation side, we have, we think there are 7 MS fellowship trained rehab doctors in the entire U.S., and we have one of those, Dr. Mayadev. We have also a physical therapist and an occupational therapist that all they do is MS. Also on the physical side, we have Pilates classes and yoga classes. I obviously would not know how to do those classes myself, so we need help offering those. Keeping people in the community, I think, is really important, and we have 5 different support groups, which is important, but support groups are not for everybody. So we have these other offerings, and music therapy is one of these. We have also a Get Your Music Back program where it's a bunch of people that are professional musicians. They'll give you lessons on guitar or keyboard or drums. And if you have MS, you can come and get free lessons for that. We have a book club, a movie club, a craft club, barbecues, holiday parties, so things to just get people back involved in life, which often falls by the wayside with a chronic disease. The one program that is only about 2 years old for us and is unique, I believe, is what we call an adventure guide. And Simon, our occupational therapist, runs that, and his job, half of his job, is to organize field trips to get people involved in fun activities. And some of these include sailing, camping, rafting, going to the theater, things like that. I might just leave you with one example that he takes people skiing once a year, and it's people of all abilities. So they have a sit ski rigged up so that you can steer this with your head. And there have been patients that can't move their arms or their legs that have done downhill skiing with this thing. And I can tell you that when you see them in clinic, it may be the middle of summer, but they are still revved about that one adventurous thing they were able to do. So that's why we have all these supportive services, is that you need a whole team to offer that much and try to patch the pieces of each person's life back together, because each person is unique.
Wow, that's amazing. It sounds like it's probably impossible for any one person to take advantage of everything that you offer, but I guess I wonder, how common is it that people just kind of dig in and really do a lot of what you have available for them?
Yeah, each person has their own little niche, and some of them are participants in a lot of our activities, but if you were a musically inclined person, they tend to gravitate toward music therapy or the band, the Get Your Music Back. Or if you were kind of a physical or outdoors person, they might do some of our outdoor, literature, art. We have an annual art show as well. So people tend to gravitate toward areas that held their interest before, and then we can try to build that back at least somewhat so that they can preserve that part of their former life.
Great. Cool. Thank you very much. All right. Well, maybe back to Dr. Eisenberg. You've talked to us about the importance of collaborative care and decreasing isolation as a way to prevent, delay, or slow the progression of dementia. And we know you probably have some other great tips for healthy aging. Can you share some of those tips with us?
Sure, gladly. So I talk about the 7 habits of healthy aging. So number 1, the importance of physical activity, and that's cardiovascular exercise, 30 minutes, 5 days a week as a goal. And of course, when you're thinking about exercise, there's 3 other components, specifically balance training, strength training, and stretching. But the cardiovascular piece has been demonstrated to grow neurons in areas that are vital for learning and memory. Number 2 is a healthy diet. The Mediterranean low salt or MIND diet has been shown to reduce your risk of Alzheimer's. And for those who have dementia, it can improve the the rate of progression or slow the rate of progression. Also, limiting alcohol, really important. If you're a smoker, stopping smoking. 5 is really challenging the mind to learn new things, or lifelong learning. And then, a positive outlook. We know that repetitive negative thoughts, anxiety, and depression can increase your risk of dementia. And the obverse is true. A positive outlook, positive associations around aging are actually protective. The lifelong learning also cultivates something called cognitive reserve, so you can tolerate more change in the brain without actually having clinical symptoms. And then lastly, really, is this working with your care team to make sure that you're not on any medications that are potentially harmful, or you are taking medications to manage your blood pressure or your diabetes or your hyperlipidemia, for example. So those 7 components are really key and can impact or help you to reduce the risk of developing dementia. And, yeah.
Wow, great. Yeah, I've heard about the concept of exercise inducing growth factors that build not only muscle, but also healthy connections of neurons in the brain. And to me, that's amazing. Do you know kind of what level of exercise is necessary in order to get that benefit?
So there are some studies looking at high intensity interval training and the benefit, but neurogenesis, or the growth of neurons in the hippocampus and entorhinal cortex, as well as synaptogenesis, or connections in systems, and angiogenesis, or growth of blood vessels, has actually been demonstrated with 40 minutes 3 times a week. So I would say that you should do what you can do. There is some data, though, about high intensity interval training or more vigorous exercises being more neuroprotective.
Great. More is better.
Pardon me?
More is better, I guess. Great.
And do what you're going to do. So if you like tennis, play tennis. If you want to go for a swim, you want Zumba, what's the best exercise? The one you're going to do.
Right. Great. Thank you. So yeah, Dr. Bowen, we know that MS impacts not just patients, but their families and the people they love and love them. How does the MS Center support the family and the caregivers in addition to the patients?
It's unusual to have just your patient affected by a disease like MS or Alzheimer's. It's really the entire family and even their surrounding community are affected. So I think the best care really acknowledges that and tries to provide support structures for family and caregivers as well. In our center, we have psychology and psychiatry to help people with counseling. They can counsel the patient, they can counsel the spouses, they can counsel them both together, and they can also involve the children, which I gather teenage children seem to be one of the areas that our patients seem to value most, of trying to get the children to understand the parent's situation. I mentioned jobs before, and it really made me feel good recently, because I saw one of my patients who just had a horrible job situation and was really not going to be able to continue this job because they were unwilling to do job accommodations, even as simple as giving them a disabled parking place, which by law they have to. But our vocational counselor got involved and was able to inform them about the importance of doing job accommodations. Anyway, it did me good, because I just saw this patient and she was able to keep that job, and she's now retiring out of that job 6 years later. And she's retiring because she's retirement age. One other thing is to help patients and their families is, as I mentioned, we have 5 support groups, but one of those support groups is specifically for family members. So they have other support groups that meet at the same time that the patient can go to, but the caregivers have their own support group so that they can help each other. Also, all the activities that I mentioned previously are open to the patient with their family member. So if we do kayaking, for example, they have two-person kayaks that both the family member and the patient can go together and kind of start rebuilding some of those shared experiences that are important in relationships. So we really do try to acknowledge the contribution of the family and help them adjust to the disease.
That's great. Just for my own curiosity, when you bring in families or caregivers, they're not the actual patients. Do you run into any kind of confidentiality problems or billing or money-related issues, or is it structured in a way that they can just kind of seamlessly come in and participate?
I think the most difficult part of it is if you're having counseling of the family member, because then you cannot bill it to the patient's insurance if it's not the patient. They'll often come in for couples counseling, and as a couple, you can bill for that. One nice thing that we have for the past several years, in addition to our MS psychologist who has done nothing but MS psychology for over 20 years, we have at any one time 2 PhD students who have to do a 1-year internship, and they spend a year at a time with us, and they are overseen by our psychologist. But the advantage of that is that they're not fully licensed and trained yet, so they can't bill, but they're free. And they can, if you need 5 times a week counseling, they can do it.
Wow, that's amazing. Great. All right. Well, kind of back to Dr. Eisenberg with pretty much the same question. We understand that the Center for Healthy Aging doesn't have the breadth of time to be able to put these supportive measures in, but what kind of things would you envision helping to support family members and caregivers for people with dementia?
There are a couple of specific programs that I want to talk about. One is called Learning the Ropes, which is a program for people with early memory loss, mild cognitive impairment, and then their family care partner. And we know that people with mild cognitive impairment, about 6 in 100 will go on to develop dementia. So there are real opportunities there with skills training and different scaffolding approaches to improve functioning. So that's a program that we offer for individuals with mild memory symptoms or mild cognitive impairment and their family care partner. And there's mnemonic strategies as well as these lifestyle skills and attentional practices, as well as family education about how to best approach somebody with memory loss and support that individual, that beloved. And then there's also a program called Compassion Cultivation Training, which is a program that was developed at Stanford with insights from neuroscience and psychology and through contemplative scholars. And this program, which is an 8-week program, has been demonstrated to strengthen your resolve for compassion, and also to help support emotional balance and to cultivate resilience. And these are factors that we need now more than ever. And so they're really skills that people can develop over the 8 weeks to meet the challenges of come what may, as it were.
Great. And these supportive programs that you want to or are bringing in, are they easy to do? Do they cost anything? Are there people that have to be incorporated to offer those programs? How does that work?
So they are outside of what are medical visits, and so they would require philanthropic support, and they're really value-added programs. The Learning the Ropes program requires a neuropsychologist and a social worker, because the program is a 2-hour program over 6 weeks. And the first hour is with the individual with mild cognitive impairment and their care partner. And then the second hour is a breakout where the person who has mild memory loss will focus on these memory strategies, as the mnemonic strategies and scaffolding and lifestyle approaches. And then that's taught by a neuropsychologist, and the family care partner would have a breakout in a group setting where there's common learning and lack of isolation and community support, to see that he or she is not so alone, and that there are skills and strategies that can be effective to cultivate that sense of connection or that sense of confidence to meet the challenge, which is resilience, right?
Yeah, great. Great. All right. For our next question, we can't really ignore the fact that we're in this time of COVID, and it has impacted healthcare in really, really profound ways already, and will probably continue to do so. So to you, Dr. Bowen, how do you think that COVID has impacted how the MS Center works, and what does the future of the MS Center look like in terms of comprehensive care?
Yeah, this was a huge challenge for us. And fortunately, the first case in Washington was in late January. And when we saw that case, we anticipated that this is coming and started preparing at that time. We didn't know the effects of the virus on MS or how our medications might affect the patient's risk of getting it. So back then we started writing protocols for what we thought the risks were and how to address them and things like that. We've had to continually invent new administrative processes to adjust to changes in the virus, but I'm proud to say that early on we looked at data from China about what the symptoms were, and we actually put those screening questions for those symptoms at our front desk. And about 3 weeks ago, I think it was, the CDC finally adopted the symptoms that we put in place in January. So we were fortunate in that way. The other thing is we had a flood of phone calls. It pretty much paralyzed our staff. Just dozens and dozens of phone calls a day specifically about this virus. And one of the responses to that was that we conducted a webinar in March to address coronavirus issues with multiple sclerosis. And I know we had 162 people that attended the webinar. We have also shifted most of our visits to video visits. This is something we've wanted to be able to offer for about 20 years because our patients come from a very long distance, some of them from halfway around the globe. And if we could offer a video visit, it sure would be more convenient than flying, from Europe over here or Asia over here to see us. And but the insurance rules really made it impossible to bill for that. But during the coronavirus, there was an executive order that allows us to bill. So I just got our numbers for last week, and we are at 96% of our normal visit capacity on these video visits. We can still see people in person when we need to, but most of it's now suddenly moved online. The last thing I might mention is that most of the programs that I mentioned that we offer, our classes and support groups and all that, those we were unable to continue them in person because of the risk of getting large groups of people together. So those have now all gone online, and I'm pleased to say that our participation has actually expanded. Because it's easy. Patients don't have to drive in here. So we have more people that are doing them now. The biggest loss that we've had is that we haven't been able to do as many of these adventure guide programs because there's no way to do a video version of taking people out and doing activities with them.
Right. Wow, that's great. I guess I'm wondering, with your population of patients, how tech savvy have you found them to be in terms of the ability to take advantage of these online portions? Has it been surprising or not?
Well, it's been surprisingly difficult to get people. I think the Zoom visits for online activities, like a Pilates class or something, that was not as hard. But the medical Zoom, with all of its encryption and the requirements, for passwords and all of this stuff, has really been difficult for some patients to grasp. It seems that they have a middle school child or grandchild available that really helps, but the rest of the adults struggle with it. But our staff is becoming increasingly good at walking people through. The message that we send to people on MyChart is now on its 4th iteration, and far more people are able to understand this latest iteration of instructions. So I think we're getting better at it, but it does take our staff doing a lot of tech support to help that.
Yeah, that's great. I think we've all gotten a crash course in virtual care over the last couple of months, for sure.
Yes.
Great. All right, back to Dr. Eisenberg. We know that you work with a very vulnerable and actually already fairly isolated population. So how can people stay connected when we're supposed to be staying at home? And I'm guessing that, Facebook and Snapchat is probably not the entire answer, although it might be part of it.
Yeah, so that's such an important question, particularly for the elderly. I mean, as you said earlier, we're in a time of isolation and uncertainty and loss, and the marginalized are at particular risk, and the elderly are vulnerable to loneliness and isolation. And so when we say physical distance, we also want to pair that with social connection. So that's really key, is to pair it with social connection. And, that can look differently. That might be picking up a phone, that might be a FaceTime, that might be writing a letter, the quaint writing of a letter, but all of these ways that you can connect. It's also neighbors, maintaining a distance, but shopping for the person. And like all of us, we have been providing virtual visits. So visits which are safe and which provide the care that's needed in a timely fashion in the home. And I like what you said about, having a middle schooler or a grandkid. I've definitely been on visits where that younger family member has just, like snap of a finger, sorted it out for my my dear patient and family member, because it just has not, whether it's been mute or whatever it's been. Largely it's worked out though. And I think that Seattle's pretty tech savvy and people do have a tablet or a smartphone.
Right.
Yeah.
And, I think a lot of people who are younger, middle-aged, have a lot of fear about, not wanting to infect their grandmother or grandfather, and so are kind of tend to stay away, even though, there should be ways in which they can engage. I guess, do you know if there's testing has been used as a component of helping to break down this barrier at this point or not?
I know there's rapid turnaround of tests. I think it's more about, masking, maintaining distance, hand washing, and those CDC guidelines around safety and minimizing risk in the elderly. So that's my knowledge. Yeah.
Great. All right. So Dr. Bowen, you have been saying that bringing the MS Center to fruition was a community effort. If you can tell us about the kind of philanthropic model that makes this kind of center possible, I'd love it, and what you envision for the center as we move forward from a philanthropy perspective.
Well, there are only about 100 MS centers in North America. That includes Canada, and just looking out over them, somewhere between a quarter and a third have substantial philanthropy support. In most of these centers, the philanthropy is spent on trying to keep the doors open for the medical part of it. And I think one important thing that we did at Swedish early on was we established the guideline that Swedish is going to pay for the medical part of the clinic. So there's no way to break even seeing MS patients from a medical standpoint. So basically they have to take a loss. And from a business standpoint, that's a loss leader because they do make up other revenue from other services that MS patients need, like MRIs and infusions and things like that. So we established that as a base so that all of the philanthropy in this center goes to support patient services, not to keep the medical doors open. We also salaried the providers so that we don't have an incentive to just do more unnecessary medical testing, which I think is important. So what have we used our philanthropy for? Our current space, which I wish I could walk you around and show you on the video, but you would get motion sick from the movement. About 40% of this beautiful space was built with philanthropic dollars. And it's all the part of the center that goes to patient support services, like, areas for them to have their support groups and their Pilates classes and yoga classes and things like that. It also, philanthropy was used to establish all the current programs that I've talked about, and most of that money goes to support the salaries of the people responsible for running those programs. So we've done a really good job of shepherding the money. We have a runway of a few years that we have enough money to last a few years at our current burn rate. So we have a nice cushion built up. But my biggest concern is that going forward, we want to continue these programs in perpetuity so that we're not dependent on the whims of the economy or the administration, like the hospital administration, things like that. So we are working now on trying to form an endowment to permanently support this so that we can continue to offer this kind of support for our patients really indefinitely.
Great. Wow. Well, I think that the MS Center is just a, prime example of how philanthropy can, create a destination site for patient care that is just like completely comprehensive. And so I guess my question to Dr. Eisenberg, when you're building this center that will include supportive services and research, population health, education, for you, what are the next steps in building this Center for Healthy Aging, and how do you think philanthropy can help you out for your center?
Philanthropy really has a vital role to play, and it will help improve the margin of excellence in a number of different ways. So first, for our whole person and family-centered care, it would allow us to develop programs such as a mind diet teaching program, or other types, or choral activities, or other dementia-friendly activities. We would hire a nutritionist, for example, or somebody to work on balance and cardiovascular training. One thing that I envision is, we have something for people who've had a heart attack where they come in for intensive cardiac rehab. I could imagine intensive brain training programs that would be supported by philanthropic support. Also, in terms of education, early detection and education efforts for people on the front lines in family practice and the ER and the community paramedics, who really need to have specific knowledge around dementia care, delirium prevention. Is it the right thing to take that individual to the ER, or might we better care for that individual in the home? really understanding those issues. Could that medication that I'm about to give worsen delirium or have an impact on their cognition? So working in community paramedicine as well. And then also focusing on sort of population health for prevention. That's a big goal of CARES, changing the paradigm so we understand the importance of population health and prevention. And lastly, implementation science and research so that we can unlock the secrets or the challenges of dementia, really making Swedish, an outstanding center and the Center for Healthy Aging.
Great. Yeah. Thank you. My father actually spent the last 5 years of his life with Alzheimer's, and we weren't sure what was going on at first, and we were probably fairly typical as patients and families. But I really wish we could have had something like what you're talking about to be able to take advantage of, and just understand and socialize it with the family, and use some resources to help him put things off as long as possible and to kind of shepherd us through the process. So I really hope that you are successful in putting that together. Thank you for trying. So I think that's all the questions I have. I guess, do either of you have any other concluding thoughts before we head on to some questions and answers from our viewers? Jim?
I might mention that I just think that the support of the community that we have gotten over the last several years in putting our MS center together has been phenomenal. And the reason that this is in Seattle is because we got so much support from our MS community and our philanthropists. So it really was a key partner in putting this together.
Great. Thanks. Okay, well, let's see. If there's nothing else, I think we'll go on. We have a couple of questions that have been asked from attendees. First question is, can virtual care replace in-person patient visits? That's a big one in today's world. What do you think, Dr. Bowen? You probably have the most experience so far.
Yeah, it can replace a lot of the visit. Most of what we get from our visits is talking with the patient. They can tell us how they're feeling far more than I can tell on my exam. So I think we can get a lot done just with a video visit. The parts that we cannot get done are of course, you cannot get an MRI virtually. And that's a key tool that we have to measure MS. And then occasionally it's just really difficult to tell what's going on just from a conversation, and we would bring those people into the clinic. But it's probably about 5% of our patients that we see in an in-person visit because we can't figure it out virtually. The other thing that we do that that we see them in person for is that we have a quick turnaround on our MRI so that people can get an MRI and then see us 2 hours after the start of the MRI. And we could do that by video, but a lot of patients, since they're already here for the MRI, will just see us in person for that.
Great. Dr. Eisenberg, any thoughts on that?
I concur that you can do a lot virtually. And I think that a hybrid model where, for some instances, people will need to come in, as you mentioned, for diagnostic tests or certain elements of a neurological exam maybe are done in person with more, precision than you might be able to do virtually. On the other hand, there are so many advantages to a virtual visit. You see folks in their home, they're safe, there isn't a risk of exposure or that schlep, for hours in a car or, as you say, sometimes on a plane. So I think really from a patient-centered perspective, the virtual visit can really provide what's needed in the right place at the right time in the right way.
Okay. We have kind of a somewhat related, maybe somewhat opposite question. Maybe if you can answer us, what about home visits? Is there a chance that that can happen? What do you think? I don't know if they're talking about the time of COVID or just in general, but maybe if you can address both.
I think there are certain, geriatricians who do home visits, and I have done home visits in the past. With COVID, I think it's not a prudent idea.
Right.
um, yeah, I guess those are my thoughts.
All right. This one's probably good for you, Dr. Bowen. What are the biggest challenges running a comprehensive center? I'm sure you've met a few.
Yes. Well, I think one of the biggest challenges in setting it up is the administrative structure that I referred to earlier, and an understanding with the administration before you go down this road that this is the way it's going to work, that you're going to lose money in clinic, make it up on ancillaries, and you're going to use all of your philanthropy for the comprehensive part of the program. Once you're past that hurdle, my biggest challenge right now is keeping up with what everybody is doing, because you need a whole bunch of people other than yourself doing this. And if you empower them to come up with good ideas and allow them to run with that, then things just start happening that you're unaware of. For example, the book club I mentioned, I just went by and noticed there was a flyer about this. Like, I didn't even know about a book club, but it's because our staff thought that would be cool, and so they just created it, and it's very successful. So I think just creating that culture where people that we work with and our patients feel empowered to just come forward with ideas, and you're okay with these ideas, that's what you want to create, and that's the culture part is probably the hardest.
Mm-hmm, mm-hmm. Which you've done a pretty good job in putting together, though, over the years. So maybe, Dr. Eisenberg, what do you see as the biggest hurdles, as you're going forward in the similar vein?
I mean, I think that the hurdles are to develop and build the support that's vital for these programs and services that elevate and improve the care.
Right. Yes. Yes. And they're not generally easily available within the medical center financial reality that we're in. So
that's right.
It's tough. Okay, well, I think the last two questions are kind of related. One is, how do I get in touch to make a gift? And the other is, how do I learn more? And I think that the answer to both of those is to get in touch with our Swedish Foundation. And we have two representatives, Erica Nelson online here, and Mallory Higgins. And we have a little slide here that should give you their names and their contact information and their phone numbers, and that's probably the easiest way to do that. I don't know if they're still up there. I think they might have. There we go. So please write this down, and you can call any of us, email me. I'm happy to refer on any questions to the Swedish Foundation for you. So with that, I'd like to just really thank again everybody for taking time out of their day to listen to the programs that we have here in the MS and are trying to put together with the Center for Healthy Aging. And I think that philanthropy is obviously absolutely critical to make both of these a success. So thank you very much for coming.